Good afternoon, everyone. My name is Adrienne Luckenbacher. For those of you who have not met me virtually yet, I'm the moderator for today's presentation. What is treatment? A quick overview of the ASAM criteria. I want to welcome everyone again who has not joined us already to the Opioid and Other Drugs virtual series provided by St. Clair County Community Mental Health in partnership with the Community Services Coordinating Body. We're very lucky that this webinar series is made possible by a grant from SAMHSA, the Substance Abuse and Mental Health Services Administration. We're very excited to provide this virtual series. For those of you, again, that don't know, September is National Recovery Month, so it lines very well with September being honored for the month of recovery. Before we get going, those of you who have gone to the 7 or other sessions probably have this very well versed about our housekeeping and just general information, but we always like to go over it just so everyone has everything. First off, today's session is being recorded. And we also want the opportunity to remind everyone that we really want you to encourage any questions, comments, anything that you have throughout this webinar to be using the chat feature, which is at the bottom of your screen. If time allows, at the end, we're going to do our best to answer as many questions as we can at the end of the presentation. We hope that the chat box in the corner will really serve as a place where you're able to share resources, information, questions, really making this an interactive presentation. We also offer continuing education credits for those of you that registered online at sccmh.org and chose your credits. They are offered today, but please note that this session is also being recorded Facebook Live and will be recorded for later viewings, but CEs are not eligible for any other viewings except for the live viewing today when folks have registered. Please make sure for continuing education credits that when you signed into the webinar today that you used your full first and your full last name. This is very important so we can give you the credit for attending. If you weren't able to do that, please go ahead and sign out and sign back in again using your first name and your last name full. You must be logged on for the entire duration of the presentation, and participants who are not logged in for the entire presentation won't get the continuing education credits. At any time, if you find yourself kicked off of the presentation or lose connection for any reason, just go ahead and log back on because we are able to see that. Continuing education credits are only going to be provided to those who complete a short survey and a short quiz after this webinar. Those materials were actually sent to you in your registration email, but for any reason you don't have them or can't find them, you can go to our website at sccmh.org where you registered and go down to the presenter today and you'll find any materials, documents, the quiz, the survey, the speaker's bio, all in there. So it's kind of a one-stop shop, which is very nice. And also for the webinar information for CEs, if you are doing a quiz or if you're doing a survey, that needs to be completed within 7 days of today's webinar. Like the other virtual series presentations, we have in and out codes, and I'd like to share what the in code is with you today. The in code today is September, all caps, SEPTEMBER, September. Okay, so now what we're going to do is we're going to move in today's presenter, which is Ken Heuvelman, or Heuvelman, I should say. Ken is clinical coordinator of the outpatient, I'm going to start over again. Ken is the clinical coordinator and outpatient therapist with Port Huron Odyssey House. He's been there since 2017. His desire to help people and learn began early in life and evolved from wanting to teach mathematics into a desire to help others understand themselves as they grow personally. Mr. Heuvelman has a history of working with both the SUD and mental health populations and has a background also in radio broadcasting. And with that, I'm going to turn it over to Ken.
Thank you very much. Let me pull up my presentation here. I want to thank you all for joining me today. I will say this is my first professional presentation, so a little leniency goes a long way. There we go. First oops. All right. So as this presentation, as you can see, this is a quick overview of American Society of Addiction Medicine, or ASAM, treatment criteria. Our goals for today is to just develop a basic understanding of what those ASAM dimensions are, of the multidimensional assessment as they call it, as well as learning a little bit of information about the ASAM levels of care. The reason for this is one of the things we hear as an addiction professional, many people tell us that their friends, family members, clients, or people they are working with do need treatment. They need some sort of treatment. They all got a problem. They just need treatment. When we hear that as addiction professionals, that's a very broad term that kind of leaves us to go, well, great. That's like saying you need dinner. What do you need? What do you want me to cook? This is this broad term that's used by a layperson when they don't understand the varying levels of care. In order to determine those, we as addiction professionals have very specific criteria as we look through. When you say that your friends or family members or people you come into work with need treatment, they're not alone. Based on a study by SAMHSA in 2018, as you can see, almost up to 20 million adults had a substance use disorder, with almost another 9 million having both a substance abuse disorder and mental health disorder, which we would call that co-occurring. So the need has been there. It is not going down. This is something that is continuing to rise across the country. When you say they need treatment, then the question comes, is treatment available? This is something that we notice specifically for those of us here in the St. Clair County region. That's a realistic question. Is treatment available? As you can see, some of the numbers here nationally versus the state of Michigan itself. Again, this is due through a study survey done by SAMHSA again. For those of you that have a math major or have picked up that those numbers don't equal the total, you kind of go, wait, if I add all those together, those aren't accurate. What that's counting is, so one facility might have multiple levels of care. If I operate a building and within that building I have residential and I have an inpatient and I have an outpatient, I'm counted 3 times. So that total is there's 465 basically different providers in the state. If you look at this residential, most people have heard of that one. That's what most people think of for treatment. 89 facilities in the state of Michigan. That is just over 1 per county. In the state of Michigan, with 83 counties, we're looking at, again, an average of just over 1 per county. But those of us in the Thumb, Blue Water area recognize that there are 0 residential facilities in St. Clair County, Sanilac County, Huron, Tuscola, or Lapeer counties. There aren't those residential treatment centers. So this can really show that treatment may not actually be as available as we would like. And this is probably one of those reasons when someone calls us and says, I'm trying to get my family treatment, but they're telling me I have to wait a long time or there's nothing nearby. It is one of those other issues here in the state, and I would assume nationally as well, that sure, we need the treatment, but is it available for them? So to get into the ASAM and what they are, so again, it's that American Society of Addiction Medicine. As you can see here, it's been around since 1954. It is based somewhat in a medical model. As it states, it's kind of founded by physicians and put together that way. They work to create a cohesive and one method for assessing substance use disorder and the treatment necessary, rather than having this model, that model, and all of these others to get the job done. This is generally accepted as the standard method of assessment, treatment, and then determining what is the best course to treat those individuals. ASAM has recently gone through an update, I want to say within the last 5 years. This is the newer version that they use that had some significant changes to create a better system. So we get someone in our office and we need to know this person needs treatment. They've come, they're in the office of a treatment professional, they have been referred to someone. We then have to do this biopsychosocial assessment where we look at biological factors, psychological factors, and then sociological things that are playing this role in this person's addiction. ASAM took that and identified 6 key points or 6 key dimensions, as they call it. This is what we as a professional with our clinical training, this is what we're looking for. You can tell us all the things. You can go through your whole history. These 6 points are what we're looking at, and we're trying to determine where you fit within these 6 dimensions. So that first dimension that comes in there, this is acute intoxication or withdrawal potential. What we're looking at this one is that person likely to go into detox or withdrawal from the substance that they are using? This is kind of important because some of our detoxes or withdrawals can be fatal. Those are much more common in alcohol and benzodiazepine detox. The cocaines, the heroines, and opiates, they do need some sort of withdrawal management. They also would benefit from detox. It changes based on drug. So what we're looking at in this dimension 1, the individual comes in, we're first assessing really what's their use look like? How often are they using? When's the last time they used? Are they high or intoxicated right now? All of these things come in because they require that different medical intervention. They are going to need something to intervene with the potential detox or withdrawal. This is a here and now picture, but when looking at each dimension, we also do use that history. If this person is on a 3-week relapse, they've been drinking regularly, but they have a history of very serious withdrawal. They have seizures, they have life-threatening concerns. This is something that is of note and is important because it may change the way this person's managed. And again, every addiction will look different. My use compared to your use compared to their use, sure, we might use the same number, but we're not all the same size. We don't have all the same genetics. These are some of those things that will come into play when managing acute intoxication or that potential for detox and withdrawal. If that person's intoxicated, that changes it too, because that starts a clock on when you need to get them services. So dimension 1, like it says, we're looking at that acute intoxication withdrawal potential. Dimension 2. So this is when we're doing the assessment. We're going to be looking at really any biomedical conditions and complications. What kind of physical ailments? What kind of conditions do they have? This is looking at anything from, is the client pregnant? Do they have chronic pain from a back injury or a motor vehicle accident? Do they have diabetes? Do they have hepatitis? Do they have some sort of medical condition that's likely to interfere with treatment? If this person is medically unstable, their blood pressure is everywhere. They have blood sugar that is completely unmanaged. It would be unreasonable for me to think that they can do some services because those medical issues are going to interfere. The other part that we look at is, are these medical issues, are they a cause or a consequence? Sometimes things such as chronic pain. So this biomedical concern, this individual may have a common one we see is degenerative disc disease. They have legitimate back pain that's not going away. The common way to treat that in America had been opiates or painkiller medications. It is shifting to developing other methods, but their pain may have directly led to their addiction. So it's assessing that, because now we remove the addictive substance, we're then going to bring the pain back. So it's looking at these not just, well, okay, they have these things, but is one causing the addiction and the addictive use, or is one a consequence? This could be, do they have a traumatic brain injury from a motor vehicle accident they got while driving under the influence? Is their broken arm and chronic pain acute because they fell down the stairs and broke their arm while they weren't quite with it? All of these things need to be looked at for that appropriate level of care. You're going to hear me use that term level of care for the next handful of slides. It won't make sense until we get to those. And when we look at those level of care ones, you'll be like, oh, that's what he meant. we're looking at these and we're not just identifying, but we're trying to figure out how much it's going to impair this person. What level of impairment is going on in this individual in this particular dimension. We move through it. So we have the first dimension of the withdrawal or detox. Then we have the biomedical and physical concerns. Next, we move into that psychological. So as you can see, this is how that biopsychosocial assessment, we're not just asking how often to use, when to use, okay, you have a problem. This is really taking that deep look at everything that led to this person's use and helping identify problem areas and how to best form this plan of treatment. Dimension 3, emotional, behavioral, or cognitive conditions and complications. This is the co-occurring disorders that we're going to look for. Does this person have an unaddressed mental health condition? Do they have something that is leading to their addiction? Or again, is it a cause of their addiction? This is that condition, primary or secondary. Someone is using amphetamines at a high rate. They may appear to have psychosis. That would be a primary mental health concern based on their substance use. When we remove the substance, does their mental health correct itself? Or do they have a true mental health disorder? This could be your bipolar 1, a PTSD, or something that leads to this imbalance that they then medicate with a substance. Are they using alcohol to cope with, an adjustment disorder? Are they using alcohol as a means to manage manage grief? Are they having some sort of mental health concern that is leading to their addiction? The other part of looking at this, we want to assess, is this mental health condition acute or chronic? It's a very common question I ask many people. We hear often you're bipolar, they come in with that. And the question I like to ask is, have you had any episodes of symptoms when you were sober? This is going to tell me whether or not this is a chronic concern or it's acute. So we have a person, they come into the office, major depressive disorder. They feel depressed all the time. Everything is awful. They just can't see this, anything positive. When we look at it, has their alcoholism, did they recently get a DUI? Did their significant other leave them because of their drinking? Did they lose their job because of drinking? Did all of these things happen because of their substance abuse? And if we can get rid of this addictive use or abuse of drugs and alcohol, is that going to help those mental health things go away? Is it situational, or is this something this person has been dealing with for a long time and they just happen to have been possibly medicating with drugs and alcohol? This again is another one of those major concerns. If it's chronic, we're going to want to coordinate care with psychiatric. If it's acute, we're going to explore that area. We're going to want to know, does a medication have a benefit, or is this something when we start to stop the cycle of addiction, will some of your mental health start to take care of itself? So we're looking at this. This is, again, it's the emotional, behavioral, or cognitive conditions and complications. Looking at sometimes they are the cause, sometimes they are the effect. Some of this is the behavior changes that we see. This is, they come out only when using. So only if I'm under the influence do I have hallucinations. I have behavioral concerns, but only when I'm high. These are those things that we look there. In this one, even, you're going to want to look for that general mental health condition, but you're also going to explore, should something be ruled out? Does this person deny having a mental health concern? But as you work with them, you identify that perhaps adult ADHD, you see that maybe their depression is a little more chronic than they understand it to be. Or often with a PTSD, do they realize the impact that life trauma has had on them? So it's not just, do they already have one, have they been diagnosed in the past, but do they have one that should be ruled out? This is an interesting category for addiction counselors. So in the state of Michigan, an addiction counselor does not need to be licensed in mental health care. You are credentialed as a certified alcohol drug counselor or a certified advanced alcohol and drug counselor. So your mental health condition may not be something your substance abuse counselor directly works with. So I have to have an extra step of knowledge about mental health, so I know if I need to refer out if I don't have the proper credentials or license to deal with mental health concerns myself. Moving into dimension 4. This is the one most people as a layperson can identify. Is the person ready to change? What's this readiness to change? What are they thinking? We're looking at, does this person believe they have a problem? This is the common one that we can see. Is this person ready to make the behavioral changes necessary to arrest their addiction? You're viewing many things. Yeah, they can call, but they don't show up. They call all the time. They miss all the appointments they need to. Is that an internal or an external motivation? Many people will come to our office because someone with a black gown and a gavel told them they come to our office or go meet someone with a badge and a gun and go hang out in their cell. That's something we would consider that external motivation. But we even look at, even if that person was court ordered to treatment, there is some internal motivation to follow along. You don't have to go to counseling. You can go to jail, but some people choose the counseling route. So it shows there's some internal motivation. And as a professional, that's what we work on. If that person doesn't identify a need to change, that's where motivational enhancement techniques are coming in. You're going to use things such as motivational interviewing. You're going to assess them on that desire, and how do I turn an external motivation into an internal motivation so this person moves forward more fluidly. The trans-theoretical stage of change, that is looking at various stages of change from pre-contemplation, contemplation, pre-contemplation, contemplation, action, and maintenance. We're looking at whether or not this person has decided that they want to make a change. You can live in that contemplation world. That's what most people will deal with, is a contemplation, maybe the pre-contemplation. I don't have a problem, I'm here because I have to be. Or, yeah, my problem's kind of bad, but it's only bad because I got arrested. It would be good if my boss didn't drug screen me, then I wouldn't really have a problem. That contemplation stage is the person's aware that their drug and alcohol use is probably causing problems in their life, but the significance of those problems is probably not high enough yet. Many times those in addiction, the best way to view whether or not I should change is to look at it, they say, through an economical model. If my risk and reward, cost or benefit. If the costs don't outweigh the benefit, I'll continue the behavior. Once it costs too much, that could be monetarily or social. Once it costs too much, then I'll start to think about changing. So we look at that trans-theoretical stage of change. We assess where they're at. Is this person going to need maybe some more intense treatment, maybe some less intense, more individualized, more group? What's best to push this person through? We often can see that person that comes in with what we call the right to maintain their pathology. This is a very common one with the alcohol use disorder and then the cannabis use disorder. They're both legal. Why is it a big deal? If I hadn't gotten arrested, no one would care. I'm not an alcoholic. I only drink 12 packs on the weekend. I work 40 to 60 hours a week. I should be allowed to drink because I can. When we hear this, what we look at is that client's understanding of their addictive behavior. It doesn't mean you're an alcoholic. It doesn't mean you have the world's worst problem. It doesn't mean that just because you use alcohol that your addiction is any less than the person who uses methamphetamine. That right to main pathology is that I should be able to do what I want because it's no big deal. And we look at that. The best analogy I've always used for an individual who looks that way is if you are out fishing in a boat and your boat gets a small hole in it. Do you panic? No, not really. The concern isn't high enough. It's just a small hole. Unfortunately, that small hole is going to sink your boat. Why are we waiting to address a small hole in our life until it becomes such a large hole that I've only got a few moments to get my stuff together and save it? You use that motivational technique to kind of help a person understand that having a use disorder is a range. You might not be the world's worst alcoholic. You might not drink more than others. You may not, use all the drugs. But it's looking at the impact it's having on your life and whether or not there is benefits to continued use. So this readiness to change is you're assessing their stage of change, their own understanding of their addiction, and then their motivation to treatment. Is this person open to engaging in treatment, or are they just completely, resistant? I'm here because my wife said she'll leave if I don't show up. So those first four, we've looked at acute intoxication, biomedical conditions or physical ailments, emotional, behavioral, and cognitive disorders, and then now the readiness to change. Stepping into the fifth dimension, this is where we start to look more at the psychological and sociological concerns of the person. This is the relapse, continued use, or continued problem potential. This is where we start to look at relapse prevention services. So they've managed some of the more. They've taken care of the medical, their mental health is stable. They're in this, they want to change, but these things still are making it tough for them to put the drugs and alcohol down. These next two dimensions are where you might see people who are the functioning drug addict or alcoholic. These are the people who can still kind of do it, but something keeps making it hard. Something is getting in the way. And as we look at dimension 5 and 6, we're looking to identify that something. So that way we can start to create a plan of service to address these needs. One of the big factors in this one, does this person have a history of sobriety? Have they ever stopped using before? Or have they ever had a period of time where they didn't have problematic use? If they have, that can be beneficial because they may have gained some wisdom as why they're back in your office. You can use this to reflect on what did you do before drugs or alcohol took over. We're looking at that ability to cope with and have awareness of their stressors and relapse triggers. You may have great coping skills. You just might not know when you're supposed to be using them. Some of the things that also fall into this one. So again, that coping skill, what do I do when I get anxious? What do I do when I get bored? What do I do when I feel lonely? What things can I do to stop the problem use? What can I do to interfere with the addiction cycle? Some of the things that we'll notice in this dimension 5, this is codependency, interpersonal problems. I have to have someone around me, and if I don't, then I start to get back into my addictive use. I bounce from relationship to relationship to relationship. I have to have others around. This might be, I just have a family history. I am the adult child of an alcoholic or an adult child of an addict, and drinking on weekends to excess, that's just what we do in this family. It's the, I'm a good, Irishman, I'm a good whatever. This is just what my family does. We drink all the time, so why else wouldn't I? These kind of irrational beliefs will lead to that continued use. We have to help shift that every time we hang out with our friends, we don't have to get drunk in the garage fixing somebody's boat. Every time I'm with my friends, we don't have to do this. Every time I go to dinner, I don't have to have a drink with dinner. It's really breaking some of those social integration where all of my social-based skills involve drinking. Well, I don't know what to do. I hang out with people. What do you do when you hang out? Well, we sit at the bar. Okay. We hear this is a common one too. People ask, well, how am I supposed to meet people? What am I supposed to do if I can't go sit at the end of the bar and talk to whoever sits at the other end? If this person doesn't have these skills, if they've never been social without drugs and alcohol, if all of their friends are also using with them, this person's going to need to learn new skills to manage their day-to-day life. They can only do so much before they start to get bored, and then they say, well, I haven't met any friends, I have to go back to the bar. In this dimension, you're looking at some of that unresolved emotional stress. Do they have abandonment concerns? This is maybe you're looking at the ACEs template, the adult or adverse childhood experiences, things that happen in their childhood or past that don't really meet a clinical or mental health concern, but that they're things they're still holding on to. Is there grief? Did they lose someone or something? Is there anger or abandonment? If you run a 12-step program, Dimension 5, that's going to be your resentments. What am I holding on to that's preventing me and causing me to continually relapse? What things am I not moving past? Moving from the 5th dimension into Dimension 6, this is that recovery or living environment. This is the physical space. This is the things I have around me. How supportive is my environment? Does my family help me get to treatment? Does my husband sit at home and drink a 12-pack while I'm trying to stop drinking over here, and he just calls me weak that I can't handle my liquor? Do I have people who can help me if I struggle? What's my support network? What do I have for community resources? In this one, I'm going to identify if there's family or marriage interventions that are appropriate. Do we need to bring couples counseling in? Do we need to bring the kids, the family, the parents into this session and into the counseling experience in order to help better communicate, to help change the family as a whole? It's that one where a person can go to treatment for a long time, they leave treatment, they come home to the same environment, they relapse. I come home, I go to the same job at the bar, I don't understand why I can't work as a bartender anymore, because your likelihood is increased. This is also looking at some of those other supports. These are also known as the barriers to success, or some of those things that just make it that much more difficult to be successful in recovery. If I need to get into counseling, if I need to get into treatment, do I have transportation? Can I even get there? Do I have the educational needs to move forward? So I may need vocational training. I may need to get a job. But before I can get a job, I need a GED. Do I have the ability to do these? Do I have legal concerns? So now I can't get a job because I have some warrants and people can't really know where I'm at. So I've got to help address the legal. Then I can address the employment. Once I address the employment, then maybe I can buy a car so I can transport myself. Then I can think about having my own place to live. So these are those other things. And again, just saying it that way is overwhelming. But if I've burnt down my bridges in addiction, I might not have any of those things. And what I need is a supportive environment. That could be recovery housing, that could be the treatment facility itself, that could be, going back to mom and dad's house or brothers or sister's house and finding somewhere that gives me this structured recovery and living environment. These concerns are some of those others that we look at. So as I push through the 6 dimensions, I'm looking at each one. And then as a clinician, and this is the part I'll probably touch on the least right here, this is where clinical experience and clinical training comes in. The ASAM book is very great in helping understand this. The more you do it, the easier it gets. But I've got a rate on a multidimensional risk rating. What is that? So I take each dimension and I'm basically going to score it or rate it from 4 to 0. As you can see, 4 is the critical, 3 serious difficulties, moderate difficulties, mild difficulties, and no current risk. So dimension 1, acute intoxication or withdrawal, I'm going to rate it 0 to 4. They haven't used in a month, 0. Dimension 2, biomedical concerns. I'm going to look at how much is this distracting them and how much support are they going to need to make it no longer a concern. Emotional or behavioral health, I'm going to rate that 0 to 4. With dimension 3, you do also look at the severity. What's the lethality of this? Does this person's depression, do they have a recent suicide attempt? That's going to significantly bump it up and change the direction of care. If they attempted suicide last week and nothing's changed, I'm not likely to go to an outpatient level of care. They need to be stabilized. So with that dimension 3, you look at the lethality as well. So you run through all the dimensions: readiness to change, relapse potential, and then recovery environment, and you're going to rate it 0 to 4 on how much impairment or how far off that specific dimension is in that person's life. So you've taken this holistic look, the biopsychosocial assessment. You've looked at all the different areas of life, the biological, psychological, and sociological factors of this person's addiction. And you get this good snapshot of where they're at. You're going to look at the history the person has, and then the here and now, and you're going to apply all of these ratings to it. Okay, now I understand what's going on with the person. I now have almost a problems list. So the beauty of this ASAM criteria is you've nailed the dimensions down, which in each area you've identified problems or concerns. Okay, so then I can take that problems and concerns list and I can take those directly over to my treatment plan, my plan of service. So I can literally look and go, in this dimension, we got to work on these. Dimension 5, we're going to work on these. 4, 3, 2, 1. We're going to slowly work through all of these problems until I can turn down that risk rating in each one. Not by coincidence, you can see that these range from basically a level of care 0 to 4. These are levels of care that are dictated by the risk rating on that multidimensional assessment. So various dimensions will flow chart you to specific levels of care. That's that clinical expertise and training that helps you identify which one makes most sense. There's a matrix for high here, low there, high here, that helps direct what is the best fit. When determining a level of care, we want to choose the least restrictive level of care possible. So you may have someone that you think is way off, but they may not need housing because they don't want to lose their job. They have a stable home, they have a supportive family, but their addictive use is pretty high. Okay, do we have a level of care that fits that? Do we have a level of care that fits the more severe? And it depends on where they're at with which rating on which dimension that can really put you in that appropriate level of care. And I think, as I mentioned before, we can recognize when someone needs treatment. They need help. Life is not all right for that individual. You can be a nurse, you can be a school teacher, you can be a family member. You don't have to be an addiction professional to notice in someone you care about or someone you know's life that they're off. Things are not working to the best of their ability. But when you say, I need treatment, what does that mean? So first, we just looked at how we're going to assess that person and what level they might need. Next is going to be, what is that appropriate level of care that's going to get the person that treatment you recognize they need. This is that one that I will say, this is the one that as an addiction professional, when people tell me what others need, I cringe, because we train in this, you maybe not. That's A little personal disclosure. This is the one I will see it in court papers where you are court ordered to a level of care that makes no sense from a professional. I reflect it back that I don't sentence people. Please don't sentence them to my program that you don't understand. So that first level of care is early intervention. This is what we'd love for everyone to have. This is almost prevention, but we're not in the prevention world. We are in treatment. This is at-risk individuals with substance use concerns. These are often your non-clinical. They drink, but not to an excess. It hasn't created clinically significant impairment in their life. We're looking at indicated or secondary prevention. Indicated prevention, that is substance use below clinical level. These are the people that have been identified as having a drinking concern. This is your DUI course. You might drink once a year, but that one time you drank this year, you overdid it, crashed your car, and now you're arrested. So the courts recognize you need some level of treatment, or it's recognized that you need some sort of education to make it just a substance use concern and keep you from developing a substance use disorder. That's that indicated prevention. You are using the substance. You've smoked marijuana before. These are the ones you'll often see school-based and court-based will be a lot of places that do it. SBIRT is your screening, brief intervention, referral to treatment. We can come in and spend about 15 to 20 minutes talking with you and then doing a quick assessment through the dimensions and determining what you need best. EAP is an employee assistance program. You showed up work a little bit less hungover, a little bit more drunk. You don't necessarily have a problem. It was just your bachelor party and you forgot to, go to bed. So they send you through some level of treatment, some education on substance use disorder to make sure that your use doesn't become that problem. Secondary prevention, we're looking at those specific population groups that are at risk. They've been recognized as at risk. We call those teenagers. Also shows up with the low socioeconomic or minority status, that we're going to run a program through the school and educate youth on why they may not want to use drugs or alcohol. Early intervention can happen almost anywhere. This might be the work meeting you guys are forced to sit through, clinical settings like an outpatient facility that does some education. You can see it in a hospital. Our agency operates what's known as Project Assert, which is another SBIRT type intervention. So you showed up at the hospital intoxicated, you had an accident, or any of those, you can then get those quick intervention things to help move you from having problematic use. The next level of care we have is level 1 outpatient. This is organized around the severity to address behaviors. It's often a step down or a final step of treatment. It's good for those who are court ordered, those who don't want to come. The best sell on outpatient is you get to go home. You can come see me and then you get to go home. This is the level of care that I consider that most people refer to as counseling versus treatment. Most people think you need treatment, you need residential, you need counseling. That means you go somewhere, you talk for a little bit, you figure it out. This is a wide range of intensity. This ranges from meeting with someone maybe once a month to maybe 2-3 times a week, attending a couple groups, maybe an individual session once or twice a week. It's really good for those that have got some level of sobriety, but they're still struggling to maintain it. So this can be that relapse prevention. I might have a year clean, but my mom just died. I don't need to go to treatment, but I really want to drink. So I need something to help me get back on track and restore the stability of my recovery. That's that level 1 outpatient. Taking a step up from that is intensive outpatient. And for those of you that are linguistically special, that means it's more intense. This is a specific range of 9 to 19 hours of structured programming. You're going to be coming in for, maybe 3 days for 3 hours a week. So maybe 6 groups in an individual session. This can bring in family. This can be recreational therapy. An hour or 2 of it might be playing volleyball out back. You're going to want to use that interdisciplinary team approach. That means recovery coaches, maybe you're coordinating with a medical provider. You might be catching up with their, mental health medications, getting them into a PCP. This is taking those steps that are, maybe my ability to not use this week is a little bit harder. So I need just a little more intensity to remind myself I have a problem. This is that 2.1 or intensive outpatient. Stepping up the ladder, we come to partial hospitalization, also known as day treatment, 20 or more hours. This is clinically intensive programming. You're probably going to spend 5 days a week, maybe 4 days a week for, 5 days, 5 hours a piece. That partial hospitalization, I'm going to spend there most of my days engaged in some sort of treatment services. But again, I go home. I have that safe dimension 6. My housing, my community support, my family is behind me. I've got something to fall back on that can help prevent my addictive use because I've got someone there to monitor me. Levels 2.1 and 2.5 are very often added to outpatient assisted recovery housing. 3-quarter houses, sober homes, or any of those would be that level that often is paired with this. I might not have a supportive structure. My dimension 6, if I went to my parents' house, I'm going to be high as they are. So I don't have that to go back to. So you create a structured environment, but I'm still allowed to go live and do some things. So I'm not bound by a residential program, but I still need a lot of treatment. That outpatient assisted recovery housing with a 2.5 is very similar to a 3.1. It looks and functions similar, but they do have their differences. Next, we jump into the level 3. All of the level 3 treatments, and again, they're going to be 3 dots, 3.1, 3.3, 3.5, 3.7. These are clinically managed residential services. This is where I go somewhere. This is what most people, again, consider treatment. I go to a Sacred Heart. I go to a Meridian. I go to a Flint Odyssey house. I'm going somewhere, and you'll see me in a few weeks to a few months. This is where I have had to leave my situation and go. The main points of this is, again, that emphasis on the therapeutic atmosphere. There's something about leaving my environment and going somewhere for treatment, to not be comfortable in my own bed, to not. This is that huge point when I really can't break that cycle of addictive use at home. I've got to go somewhere. I've got to put work on the back. I got to put kids on the back burner. I can't think about my relationship too much. I've got to stop and focus on me not using. The lowest level of the residential treatments, your 3.1, low intensity. It's 5 hours of low intensity treatment daily. And you have this ability to practice and integrate your skills. I can use the coping skills. I'm part of something. I'm not in group all day. I'm not just all day taking lectures, taking clinical, sitting in with a counselor. I'm spending some time developing and working on the skills that I have learned. I've taken some time to stop the addictive use, but I really can't manage my life yet. I know how to not get high today, but I'm not really good at doing, those basics I'm supposed to do. I don't have the job skills. I don't have, the ability to not give in to my grief, to not give in to anger. I've got to work on some of those things still. Clinical focus for this, dimensions 4, 5, and 6. 3.3 is the least common. This is the population specific. We're looking at the cognitively limited or impaired. These are the people who might not be able to have the ability to care for themselves with or without their addiction. Severe interpersonal or coping deficits, really good focus on helping them learn to maintain their activities of daily living or ADLs. Again, 3.3, least common one, just because the number of individuals that fall into that is not there. 3.5, high intensity. So as you're seeing, we're going up. The amount of disruption in life is getting high. So those ASAM dimensions 1 through 6, they're getting bumped up into those 2s, 3s, maybe a 4. The look of this one, again, is that focus on healthy reintegration in the community. This might be something you see going on in a pre-release center, might be something involved with the jails or something of that nature, where we're really working on getting all of those skills figured out so I can go back to living a life. I can go back to thinking that I might work a job again, that I might be comfortable living with other people, that I can get back into the community. The goal, again, I might start in one of these 3 7s and 3 5s. As I work on my ASAM dimensions, I'm moving down levels of care. It becomes less intense, and I start getting back to this whole life on my own. 3 7, we're looking at medically monitored. This means you're going to have nursing care, physicians monitoring. You have medical on call. You're still got a lot of dimension 2, dimension 1 problems. Possibly that dimension 3, you're still not stable. You need to be stabilized before you can really start to address the substance use disorder. You've got to manage your medical, your psychological. You've got to start to turn down some of that before you can even start to address your substance use. As it mentions here, often an acute care hospital or a psychiatric facility. Then the final level of care that we do have, medically managed intensive outpatient. You're not making it. You're probably in jeopardy. Life is not good. You've done some damage, most likely, and we really need to stabilize. This is, your addiction physicians are on staff. You're on call. You're hospitalized. This is those individuals that truly need to get not just stable, but you need to get out of a critical care level into some level that you're not going to be highly concerned. We're not looking at 4, 5, and 6 here. Dimensions regarding your readiness to change, we're not there. We're not working on who you're going to hang out with on a Tuesday night when you go home. We're not there. 6, we don't need to know whether or not you're going to go back to work this week, because we need to know if you're going to go back to work ever. This one is we're highly looking at, probably some 3s and 4s in dimension 1 and 2. You detox and it doesn't go well. Your medical concerns are bad. Your transplant list, but we don't know if we can unhook you from the machines. That's that medically managed intensive inpatient. So as you can roll through it, you do your initial assessment, you identify different dimensions, then you rate them. Okay, their medical's here, their psychological's there, their home environment isn't good, and you slowly play this ranking game of each dimension. Then you take that knowledge and you place it to the appropriate level of care. So you got this person that needs treatment. You need help. Okay, we get that. You need help. But what help is going to do you the best? Because if you put the person in the wrong level of care, if this person just needs to go maybe to a couple groups a week, not lose their job, not have to spend a month or 3 weeks or 28 days at a treatment facility that really disrupts their life and does more harm. If I push someone into the wrong level of care, they're not likely to come to it when they need to. You have that person that qualifies for a 0.5. Yes, they showed up drunk to work. Okay, but things happened and they showed up drunk. If I tell that person they've now got to go away for 28 days, when all they really need to do is take a look at why they had a really, really bad week and ended up not getting sober before work. So it's identifying what's the real concerns, what's the likelihood that this is going to do more harm if we don't stop it or resolve the conflict, and how can we do that while allowing you to live the most independent and free life possible? Because we want to have you living while recovering. If I take you and place you in a controlled environment and you stay in that for too long, you haven't developed the skills to step out of a clinically managed environment into a therapeutic outpatient model where you're then doing some of the things but going to your own home, doing some of the things less, going home, going to work, raising a family, coming to counseling occasionally, and so forth. It's a really weird model. And it's one of my favorite things to joke about with counseling is if I'm good at my job, I'm going to put myself out of work. My goal is to help you come in, with this high ranking in the ASAM dimensions, really high, and we're going to work you down to where you don't need us anymore. My goal is to bring you into my office, help you get to a point where you never have to come back to my office again, where I can kindly say, and I never want to see you again, because we've resolved all of those things that were holding us back in each dimension, and we don't need a counselor anymore. I want to create autonomy. I want to create this ability for you to take care of yourself without needing ongoing. And that's kind of, again, that brief overview. You have the dimensions that assess where you need to be and what's going on. Then we use those to determine how intense your services should be. With that, I think we do have a few minutes for questions and answers if we wanted to get to that. I don't know where.
We do have some questions, Ken, so I'm going to go ahead with one of them.
So I didn't explain it good enough. Okay.
Sorry. I think you did good. All right. One of the questions is, can you do these dimensional assessments as an RN, or do you have to have certificates or particular training to complete them?
So an ASAM assessment is a clinical assessment. You should be having some level of credential. If you look at it for the addiction world, if you're an RN and some of these are things you want to learn, you can get the trainings in it to understand it. But to create a true actual assessment, you would have to be considered that addiction professional, which is that CAADC or CAADC, that you're doing a clinical intervention. But I would say as an RN, you can definitely know it, and then you better understand it. So when you talk to someone or refer them, you can help get them to the right place.
Okay, we have time for one more question. Regarding those that are incarcerated, when you're completing the ASAM on someone involuntarily sober, do you base their scores on the severity of addiction while incarcerated or prior to incarceration?
That's one of those strange ones. While they're actually incarcerated, they're considered in a controlled environment. So some of the things that they're able to do, their relapse potential goes down. They're not as likely to be able to continue to use. But you do have to take, so what ASAM tells you to do is to use the here and now, but also take into consideration historical context. So I would say using that, yes, right now they might have 3 years sober, but they just got paroled this week after being in prison for 3 years. Do they have these things forward? So as someone working in the jail, while in the jail, you're going to look at what they were struggling with before they came in, providing services inside the jail. But when they leave, they're going to want another assessment most likely, because technically they're changing environments. So that ASAM 6 is drastically going to change.
And so we're rounding out at about 2 o'clock. So we're going to go ahead and wrap up our questions right now and go ahead and do our wrap up. So we want to thank Ken so much for your time, all your information today, especially on such an important assessment.